So thank you for being here, because this is not a CME-based course. This is something that we hope we can get some interest in. We also want your feedback here today in terms of, your thoughts on this, because it is kind of new. When we approached legal counsel about this, we said, has any other association you know done this? They kind of said, none that we know, and they work with a lot of associations. So it's kind of new, but urgent care is kind of new, so why not? Once again, you can use the app if you have questions. And, what is the Gateway to Better network, and what are we doing with this? And really, our goal is to aggregate member centers across the country to bring them together with a goal of bringing new patient opportunities actually to your door. And, when we talk to most urgent care centers out there, there are at least some times of the day when they have capacity, and we feel as a member benefit, we would like to be able to help you fill some of that capacity that you have. We know, being your association, when you pay your dues, it's a value proposition that we owe you, and what better than bringing revenue to your centers? Our network will be a connector. It is not the payer. We're not going to be the biller. We are the marketing arm that will connect opportunities for you. It will pursue non-traditional cutting-edge contracting opportunities. We're not going to go out and try and contract with Cigna in your market and become going to commercial payers and that type of thing. This is a different concept to bring different kinds of patients to your door. And we think the new environment for value-based payment and population health opens the door for new opportunities. So why do we want to create this network? We are a very fragmented industry. When you think about it, the top 20 urgent care center operators comprise 20% of the market. That's the top 20. So, when you think about it, 80% of the urgent cares out there are still, smaller. They're not the 100 clinic groups. The top 20 retail clinic operators comprise 95% of their industry. So if you think of Minute Clinic, the Walgreens Clinic, all of those top 20 retail operators will compose almost all of their market. And CVS Minute Clinic alone represents 55% of the entire retail clinic market. So, and we all know, you've probably heard about, Aetna and CBS coming together. They have created a national network. They are launching their concept stores in Houston. And they really want to be disruptors to healthcare. But when you think about it, with one single contract, Minute Clinic and Aetna can go to someone like the VA, for example, and say, we can really make this easy for you. One contract and you have 1,000 delivery sites across the country. We don't have the ability to do that unless we join together. From New England Journal of Medicine Catalyst, New York Presbyterian and Weill Cornell Medicine in Columbia set forth on a path to be national leaders in telemedicine. And Dr. Peter Fleischgott, who is the Senior Vice President and Chief Transformation Officer at New York Presbyterian, is quoted, and this was like 3 weeks ago, to say, the days of bricks and mortar urgent care are going to go away. The capital expense is too much, and digital medicine is here, and it's here to stay. We all know there are some threats out there. I just don't happen to believe this necessarily. When you think about the kinds of patients we see every day, digital medicine still can't stitch up a laceration and do take an x-ray, the kinds of things that we're doing in our centers. But it does tell me that we need to be a little bit disruptive again. And, they're changing. We need to change a little bit. So, we're wondering if we may all sometimes feel like we're suffering commercial payer dependency. Our benchmarking report in 2017 said 67% of visits were related to commercial payers in the urgent cares that responded. And in 2018, it went down somewhat. 47% of visits were related to commercial payers. When we look at it over the years, it's consistently been about 58%. So if you take 2017, 2018, we're very much the same, meaning half of our business is coming to us from the commercial payer market. But what we have seen, like last year, 17 to 18, is more urgent care centers were shifting to Medicare. I think that's just a natural shift. We see more people moving into that segment. People who were users of urgent care medicine when they were in their 40s and 50s are now 65 plus, and they continue to use, urgent care centers. So that's kind of a natural transition. but more picking up Medicaid, employer services, ACMED. We saw a big increase in the number of ACMED visits being seen in urgent care last year. A report by the American Medical Association said 73% of major metropolitan areas have an absence of health insurer competition. So what does that mean? When you're contracting with someone, those people where there's an absence of competition have a lot of clout to set your rates. And we're feeling price pressure, at least that's what we're hearing from urgent care providers across the country, is they have, one rate and now someone is trying to push that down, or they're trying to switch them from, a relatively reasonable fee-for-service rate into relatively unreasonable global rates when you consider the scope of services that you're providing. So and this is the same study from the AM, in 91% or 344 metropolitan service areas, at least one insurer held a commercial market share of 30% or greater, and in 46% or 175% of MSAs, one insurer's share was at least 50%. So these are the worst markets across the country. If you look at them, if you're in Alabama, Hawaii, Louisiana, Delaware, you have a monopoly or an oligopoly at best. South Carolina, Michigan, most of these are the Blues, who are the dominant player, but in some it's the United. But for the most part, it's the Blues, Anthems. So how do we respond? We have seen that shift in payer mix. If we're just looking at benchmarking 2017 to 2018, it does seem like people are trying to respond to that, to look at other forms of payment, whether they're getting into work comp, cash payment programs. We have a presentation here at the conference on setting up medical discount programs. So we still have a huge part of the population. The uninsured rate grew 13.7% in 2018, despite Medicaid expansion. And cash pay represented 7% of urgent care visits in 2017. So we're still seeing that cash pay contingent, but there are creative ways we can leverage that. As I said, Medicare and Medicaid and new services, cash pay versus traditional. So our point is maybe we need to get disruptive again. That's how we got here, is in terms of becoming urgent cares all across the country. But I think we can join together and pursue some new innovative opportunities. So the challenges that we're seeing in the payer market, and these are just a few of them. Our board has been addressing this. We have a payer relations committee, health and public policy, but global rates, not necessarily good if you have retail clinics, telemedicine, and now we have ERs where we're trying to have ER diversion programs. But if you're trying to increase your scope so that you could really be there to address the patients coming out of the ED that might be a little more acute than what we're traditionally seeing, it's hard to do that when you're locked into a global rate. I mean, in some places we're hearing $75, take it or leave it. Well, who's going to hang an IV bag for 2 hours to hydrate someone for $75? And yet the pressures we're getting from some are saying you need to move these patients out of the ED, and yet the payment in that commercial market in particular is not there yet. We see payer-defined staffing models. One payer told someone recently doing a contract that they had to staff 2, not 1, board-certified ED medicine providers at any given time in their urgent care center if they wanted to be an in-network provider. And they really pushed back, saying, the payment model doesn't support that. So they reduced it to 1 board-certified ED provider that they had to have in their center at all times. We see payers demanding you have to have a physician on site at all times, those types of things. And our point is, why are we being held to a different standard than the licensing boards are establishing state to state, who have the ability to protect, or have the responsibility to protect the public? We're seeing rising copayments as a part of patient responsibility. I feel like we're providing primary care. I don't understand this disparate, $25 if you come here, $75 if you're going to an urgent care, when we're providing primary care services. Clauses limiting follow-up care. You see someone, they're geographically displaced, they're in Philadelphia, they're working, they have onset of pneumonia, they need to be there for another week, and yet your contract says, I can't follow up with this person. Then where are they to go? And networks are closing for new entrants and applicants. We're hearing this across the country. It was the biggest number we just saw on our benchmarking reports, and saying, new to a market and I can't get onto a contract, or protracted periods to get onto it, over a year to get a contract done, credentialed. Meanwhile, the urgent care is closing because they're practically out of business, because they're in one of those markets where it's an oligopoly. Just DocuTap, they just produced this, similar type thing where they were just saying, we see changes going on. In the next few years, we'll see more primary case providers shifting into on-demand care and more urgent care clinics offering services once reserved for family doctors. So, the lines are getting a little more blurred in terms of what we're offering. In our mind, in terms of what we feel like we're capable of doing, how we're addressing our centers, and yet sometimes the commercial payers aren't there. You can't do wellness services. You can't do immunizations. You can't do follow-up care. If it's not an episodic care visit, you can't see that patient. And that's problematic with where we see value-based payment, population health is going. So our initial steps are really, as I said, we're trying to create a network. We're trying to get the people in this room and your fellow members across the country to join up. We want this to be accretive to you. We're not trying to take away any of your existing business. This is really to bring new business to your door. There would be a contract between us, between the provider or the organization and Gateway to Better Network. We will create organizational profiles. The last thing we want to do is to be given someone who wants to contract with us to bring patients to your door. We don't want to be having an adult come to a pediatric practice, for example. So we will create profiles that will be provided to people seeking care, whether they're self-insured employers, whether it's someone like you're going to hear from here in a few minutes, where we already have a contract. We want to make sure we have the right profile. We don't want to send someone to you at 10 at night if you close at 8 at night. Those are the types of data that we would be gathering on you. And then we'll have a delegated credentialing process where we're going to say in the contract, these are the things we're expecting you to do. If you're an accredited center, we know you're doing them because we've already looked at you. If you're not an accredited center, we'll probably spot audit some of those centers, 10% or so, each and every year to make sure you're actually doing it. But we're trying to make it not like a traditional payer where you have all kinds of hoops to go through. If you're currently with Medicare or you're currently with Blue Cross Blue Shield, we assume, you're being vetted and you're doing some credentialing. So we will market the network. We will go out there. I just did a LinkedIn thing about it a week ago, just on my own personal LinkedIn, and someone already reached out to me and said, I want to create a work comp network across the country. I'm interested in the centers that are joining you as sites for my work comp. They're a huge organization. They already are in that market. What they don't have today is the physician component, and they would like to approach us about being that physician component. And you hear from someone today. So this is without really marketing it yet because it's chicken and egg. I kind of need to build the network before I really market it. But I think there's real opportunity here. We'll seek viable parties seeking services appropriate for an urgent care center, and then we will notify the designated contact for participating centers. So we want you to give us a contact person and who we would reach out to and say, here is an opportunity for you. And then you can opt in or opt out. If I say to you, here is a workers' comp, this is injured workers in your area, American Airlines, and, this is what they'll pay, 110% of the Medicare fee schedule or 95% of the work comp schedule. You can say I'm in or I'm out, and then that is the network that we will provide to them. You have 10 days to opt in or opt out with us, and then we will provide that list and your profiles to whoever it is we're working with. And if opting in, the new agreement becomes an addendum to your overarching contract that you would have with us. As I said, it would be delegated credentialing. You're attesting your licenses are active, typical kinds of things. These things you see up here, and I'm not going to read through them all, but certain baseline levels of medical professional liability, those are the things you are attesting to us that you have in place because we have an obligation as the network to demonstrate, we have some quality indicators in place. And these are center policy specific criteria. You have a visible sign. These are the things that would be in the contract that we have developed with our council. So my point is, I really believe a rising tide lifts all boats. There are some threats out there. We know that, but there are also a huge number of opportunities. We believe, the primary care market is still somewhat disrupted. They're not sure where they're going. I think we have a real opportunity. Urgent care owners and operators tend to be pretty innovative to begin with. I think they're less risk averse for things. And I feel like there is no risk to this. You sign a contract, you agree to certain things, and then you have every opportunity to opt in or opt out. It's, we bring the business to you and you can say I'm in or I'm out. So, as I say, we're not the payer. When the contract comes to you, it would say this is how you seek payment. All of those types of things would be written there. that we'll provide a profile to you, and then you can make your decision. So it seems to me there's only upside, and I really think we have to join together. There's a metaphor I was reading about the other day, because I'm about ready to go. I go to a lot of national parks. I go to Glacier. I go to Yellowstone. And next 2 weeks, I'm going to Yosemite. And so I just wanted to make sure I was up on my bear criteria. How do I manage? Because I like to hike remotely. And it was, if it's a black bear, grizzlies, you're toast. They said just get in the fetal position and protect yourself. But they said if it's a black bear, which fortunately they only have in Yosemite, they said get together, make yourself big, get together if you're walking with more people, get together, be loud, make yourself look more dangerous to that bear. Let's get together. Let's make ourselves look dangerous to the bears out there. And I really think there's opportunity here. I've run a physical therapy network in my prior life, and I think why not do this? So it just makes sense. So I'm going to turn it over to Rich right now.
Thank you, Laurel. I really appreciate the opportunity to be here as you open up these oceans of opportunities for your membership. It couldn't be a much more fitting setting than that. Laurel and I, we at one time walked the campus of Ohio State University together, but we actually just met this morning. So we've been working together in this new day and age, and it kind of goes to what kind of the theme of what we're talking about is that we have met on video conference and kind of the way of the new world and delivery of healthcare and the way business works. So what we'd like to do is just tell you about what we do and how we are really honored to support the Gateway to Better network and what our purpose is and some of the tools that we may bring to you. First of all is that if you look at, there we go, optimizing existing resources, and you all have great resources. We understand that. Unfortunately, in the marketplace, you don't necessarily get the credit for the resources that you bring to patients. That is what we are intending to change. Our Health in Motion network is the network that we operate and that we market to self-funded employers only. So we're not interested at this time in Medicare, Medicaid, other types of direct relationships that you have. This is the self-funded specific patient. And these are the patients that many of them that you see in your centers currently, they're carrying a payer ID card because that self-funded employer is renting the payer renting the network from the payer. There's a lot of frustration in that. Laurel talked about the consolidation, and there's a lot of frustration with the options that are available to them, and they'd much rather go direct. So national is critical because it is health in motion. People are in motion. I'm in motion every day. When I'm home at Amelia, just up 95, I go to Dr. Terrazio's Amelia Urgent Care, and I see my physician Ed. I mean, I just know him as Ed, just because he's always there. And I don't really use a primary care physician. I use Ed, and it works out fine for me. So what I'm saying is that's not abnormal. That's kind of the new norm in consumer-driven healthcare. So you have such a fragmented industry, and Laurel mentioned statistics that 20%. It's limited 20%. The top 20 have 20% of the marketplace geographically. It's hard to contract nationally because not only are employees in motion, but employers have multiple sites. And nobody within Gateway to Better or the Urgent Care Association individually has the bandwidth to do a viable employer contract. Our experience in self-funded employer contracts is that they want to contract centrally from centralized human resources, but they also want to have equal benefit opportunity for the headquarters staff as well as the dispersed staff. So what we have is that your urgent cares, you may have a near site clinic that is very viable for that central site, but you need the assistance of your colleagues to help manage the issues when people are traveling or if they're at a distant site or at a remote site. Because as most major employers is they have centralized HR and they want that service to be standardized and nationalized. The whole is greater than the sum of the parts. Here's the parts that we see that you bring to us immediately in the network. Excellent clinical capacity. There is no doubt about it. I mean, the consumers have spoken. I have, over the years, have gone to, because I've been in the managed care industry now for 40 years, is that I look at now the transformation is that individuals don't see themselves as patients. They see themselves as consumers. And I think that's really a critical for all of us to recognize, because the consumers are driven by immediate gratification from the Amazon type training that they're receiving in every other commercial market, from banking applications to buying goods and services. So you have excellent clinical capacity. You have an excellent footprint for urgent care delivery from a real estate standpoint. Phenomenal footprint. And then you have great consumer reputation. We add tools to that to make your operations more viable and more marketable to those self-funded employers. So Health in Motion adds additional viable parts, and we'll talk about that as we go through the presentation. Addressing the need, it's a busy slide. You'll have it on your app. So I'm just going to highlight a few things, is that we focus on workforce enhancement and efficiency. So our message to our employer groups is that we want to match you up with a near-site clinic. We want you to be able to have goods and services there. We want a national network of urgent care centers that when your folks are out traveling, they can get care, or when family members live far away from the headquarter operation. So workforce enhancement and efficiencies. We also do on-site, work-site clinics supported by urgent care providers, and do that in a virtual environment. We broaden the bundle of services. There's no reason that the urgent care centers cannot be the health hub for all types of services: urgent care, primary care, wellness, population health, all the services that people need, because there's a vast majority of people that are in self-funded employer groups that do not have a primary care physician relationship, and they're looking for that health hub in order to get their health care on a regular basis and a consistent basis. And the last one on the era of convenient care, new meaning to one-stop shopping, is that employers want that, employees want that, employees' dependents want that. They want access, and they want access that is consistent, and that is quality, and that presents value to the payer and to themselves as they're in higher copay programs. If you look at reducing the total cost of care, and that's always an initiative that you have to do. And I look at cost is that it's not just unit cost. It's not that, trying to grind it down to $75 a visit. That's unit cost. We're looking at the value. What's the value of the services that you can provide? But what's really important for you to understand is that what we're looking at is defined populations. You see it in that first paragraph. So we're not marketing to all people to be all things. We're marketing specifically to self-funded employers, whether local, regional, or national. And you see there's a significant opportunity in local. We have tremendous response from school systems, from municipalities, those types of locals that recognize your service and would like to use your clinic as a near-site opportunity for their employees to have access to a broad breadth of care. So what we're building in the care access area for the Gateway to Better participants is marketing your centers as a near-site clinic for a broad array of services, making your facility an exporter of clinical services directly to patients that are in a virtual worksite clinic for OCHealth, for any kind of worksite presentation of illness, and then also to be an importer of healthcare, because again, you have great real estate, you have great facilities. Why not have the health system specialist export their specialty care and you host it? We have the technology in the virtual health program to allow that to happen and to allow that to be prosperous. Again, what it is the key is that patients are now consumers. They want convenience, but they demand quality. So the key is for us to together through Gateway to Better is to create that and then to market it effectively. Again, this one goes to healthcare consumers and what they want. And this was a poll that was done. And if you can see is most of these you already are doing. It's just it's not available to everybody either through a poor benefit design or some type of a steering mechanism by a payer. But what we see is the opportunity to bring people to you because this is the convenience that they want. And then you look at what they mentioned also instead of mentioned most is that they want to be able to get same-day appointments. They want to be able to get the prescription filled at the visit, as does our employer groups that are going direct contracting with Health in Motion Network. They've asked us and demanded of us to have a pharmacy product that gives near site support as well as direct-to-consumer fulfillment at transparent pricing, because the PBM industry has been is consolidated, and I started one of the early PBMs in 1988. It's now part of Express Scripts, but quite frankly, I think that the PBMs, based on the current marketplace, are struggling to present value to the employers, to the employer workplace, and that's a struggle that they will continue to have. National Care Coordination. We've created a very complicated health system. Not we in this room, but as an industry, a very complicated health system, one that most consumers struggle to navigate. And by struggling to navigate that, it causes us to have poor outcomes and failed therapies. I do a lot of pharmacy labeling work on Capitol Hill, and we're seeing 15 to 18% of return visits to hospitals, ERs, and to physicians are due to drug interactions or fail to take your medication properly. In this day and age, it's just totally unacceptable for the investment that we make in pharmaceuticals for patients and the employers make for patients to get that type of an outcome where actually the misuse causes another encounter that they also have to pay for. National care coordination is important because dispersion of population across large regions. You see that there are companies now. You may have a manufacturing factory near your particular clinic, but the benefit decisions made for that factory are made 2,000 miles away, and you have no access to those HR folks making those decisions. But you could provide great quality near-site care, but don't have the contract or the ability to do that based on their benefit design. That's why national is important. We work really closely in the transportation logistics industries. You think about a cross-country trucking systems and the logistics that go with that. It's accessing healthcare for a rig like that, for a driver or a pair of drivers, is absolutely impossible. They're also very unhealthy, and if they don't stay healthy, they get pulled off the road and the trucking company takes a big hit financially. So if you look at multiple locations and you look at logistics and you look at the way people move around the country, and they're always in motion, is that you have to have a national presence. The other is that number two is chronic diseases. You really can't move the needle in the healthcare industry unless you have impact on chronic disease management and population health. You're all well positioned to do that, and it's an offering that we need to have you provide to round out your healthcare presence. You are all in a perfect position with your quality clinicians and with your real estate to provide a broader breadth of services. Laurel talked about some barriers that you're all having in some of your payer contracting. Those are not driven by the employer groups. We don't see any of the self-funded groups trying to drive those types of incentives to keep you from doing certain services. Quite frankly, they want more access and they want more quality. They want more follow-up. They want somebody connecting the dots, and connected care is key to that. And you can be at the health hub doing that as consumerized healthcare continues to evolve. The health inflation, again, that's that's a value to me, is it's not cost per episode. That's never been the problem. It never was a problem when I started the pharmacy business. It's what's your return on investment for investing in a certain therapy or a certain course of care, and what is the return, and is it measurable? That's how we get value into the system. And you're all well positioned to do that, but unfortunately have had some barriers to following through on some of that, and that's what we're removing. Market trends. If we look at market trends, there it is. Creating the trend. We like to be ahead of the wave, and we have some waves out here on the coast, but we always like to be ahead of them, like any surfer. Is you want to jump on the wave and be ahead of it. Otherwise, you kind of get caught in the wake of things going on in the marketplace, and you can't make your own decisions. What we're seeing in market trends is large employers, they become so frustrated with the healthcare system that they've gone to on-site clinics, where they employ clinicians to be on-site. You have to be a very large employer to make that return on investment equation work. But quite frankly, that's a competitor of all of you. When you're sitting there with a near-site clinic that can provide the same services, still keep them engaged in the workplace, so that there's not that absenteeism, so you don't have to take a half a day to go see a physician in order to manage your therapy. That's the key. It's connected near site and virtual on site. That's what we're offering as additional tools, because your clinicians can be great exporters of care to a virtual on site clinic that is on an as needed basis versus a clinic that has a full staff, a full clinical staff that is sitting around all day waiting for someone to come. And that doesn't work well for employers. And as they measure that return on investment, it doesn't go well for them on a staffed in-house clinic. Now, scope of care. Scope of care management is that we see that in twofold. We see our gateway to better urgent cares as a health hub, someone where it's a consumer-driven health hub that can do urgent care, primary care, follow-up care, worksite clinic, near-site care, chronic care management. So when that person comes in and they're struggling to manage their chronic care disease, that you're the go-to center for that. Population health management. We also see you, as we said before, as a host site for specialty care, clinical trials, those types of things where your real estate becomes very valuable. And quite frankly, we make your real estate valuable in times of day that you would have trouble having patient loads. The worksite clinic and exporting your clinicians is going to be most under demand during the business day, which is typically the slower workload time for the urgent care industry. So we see as a scope of care is going to be absolutely critical to driving the consumer health hub, and the consumers are going to drive it. They're looking for one-stop shopping. They're frustrated with the maze. I mean, it's a terrible maze. I don't know if you all flew here or not on Delta, but you see the new Delta napkin for the Diet Coke. It's got this big maze going around the can. Well, that's the reality of healthcare in this day and age is you have patients, consumers, they enter this maze and they get fatigued in the middle. They don't finish their course of therapy. Nobody's helping them finish. And it's what's causing us our outcome challenges. Patient engagement is one of our key focus with applications that engage patients. How do they understand where to get contracted healthcare? Where's the best places to get it? Where are the most reasonable places to get that within their benefit design? Part of what we do is we work very closely with the benefit brokers. Those are the folks that have relationships, long-term, sometimes 20-year relationships with employer groups. And they bring the pieces to the puzzle together for the employer to make a decision and to build their benefit. What we do is we work with them during the benefit build process. We don't go in and sell them our product. We work with them to build their product. That's really critical. And that's how we get all of you involved in the right way within patient engagement and benefit design. Again, this is national employer contracting, and that didn't go, sorry.
You got a message here.
Page is not active.
Click on this message to fix it. There you go.
Did I
Try again.
There we go. Sorry about that. National employer contracting is critical because you have to have geographics. We don't have to have everything, every area totally covered, because we do have virtual health, which allows us to cover it through different import-export type of environments, as well as directly to, for instance, we talked about that logistics driver is that we have the ability to connect them from their smartphone directly to you in a HIPAA compliant virtual waiting room, so that you can see them at that time and track them on the road, help them with their issues, get them a prescription at their next stop or whatever they need to do in order to stay healthy. But the vast majority of people, or vast amount of people, don't have any PCP, so they are looking for access to care. Efficiency of access attributed to employee populations can't be created with brick and mortar alone. That kind of goes with Dr. Fleshout's observation that brick and mortar urgent care is a historic event and it's going away. We don't believe that. We believe that it's going to be transformed because you are the health hub. You have the ability to be the health hub. You need a physical presence because there's so many things you can do physically, but you have to have an outreach virtually to reach more people, to reach them more effectively and more efficiently. So putting in a unified platform, which we have, is that it allows you to be urgent care near site, but also allows you to reach into the employer site, reach into the home if needed, reach into the occupation where the person's on the road if needed, so that you can take your footprint of Gateway to Better, 3,500 urgent cares, and spread that over a larger geographic. And I like you to think of it as a hub and a spoke type model. And your spokes can be very long and very effective. The key here in number 4 is convenience is critical. Again, they're consumers. They're being trained as consumers and being trained very well. Convenience, quality, they don't sacrifice either one of those, and they want personalized healthcare. They want to be recognized. They want you to understand what they're going through, what their therapy is. Part of our Health in Motion infrastructure is a record that travels with the patient and interacts with all of your EHRs. So that's what we're working for. We're working to make sure that patient, no matter where they're seen, that clinician has information to make a difference for that patient. This is a local employer contracting that we've been working on. I won't bother you with all the busyness of the slide because it's got a lot on it. But this is a local case. This is actually a municipality which is within probably their administration building is within I'd say probably at least 200 or 300 yards from the urgent care center. So perfect near site situation. And it's a direct contracting where basically the center is their healthcare benefit. They walk in, they walk out, the guys at the fire station, the paramedics come in and chat with the doctor all the time just when they're waiting for a call. I mean, they become the health hub for that entire population. Created great value. 100% of the employees have had health assessments. They're all getting population health in combination. We've done a collaboration. We built the program with the broker USI. We have a population health agreement with Trinity, the local Trinity health system that assists us in the population health. And then our Express Med Urgent Care does all the primary care, urgent care visits. And the vast majority are the 9 to 5 during the day. So they don't really impact those busy hours of 4 to 8 at night when other folks that are coming in commercially. So it's been very, very valuable. What are they demanding that we improve? Well, first of all, let me tell you some of what we've proven in this of the urgent care advantages. This is from the urgent care operator. Is that it's increased cash flow. He has a regular cash flow based on a monthly prepayment from the city. Loves that cash flow. Decreased seasonality because he has patients coming in all the time. Increase workday balance. So these folks will pop in mid-morning. They're at work. They're not feeling well. They'll shoot in mid-morning, not your later in the day where you typically are the busiest. And then patient relationships. They grow these relationships and they get these return visits. And as everybody knows in any consumer-driven industry is that it's very difficult to recruit a new consumer. If you have one that you're satisfying, it's a lot easier to retain them. And the employers and the employees love the access, and it's worked out very well. I'm going to speed it up just a little bit here. This particular, we kind of described this before. If you look at the left, this is the old way. This is basically what we call steerage. I mean, and like I said, I've been in this for a long time since the HMO Act of 1985 created managed care. And we've never really managed care in all those years. We've managed finance. We've moved people around. We contracted differently. But that industry didn't manage anything. They managed money. They didn't manage care. And that's a big challenge for all of us as we go forward, because in the care coordination tools that we all have available to us now, there's actually going to be a patient management that's going to be part of it. We'll skip over the changing the dynamic because that's kind of a summary of what we're doing to get those outcomes. Here, changing the dynamic is that we use, as part of our virtual outreach and our virtual platform for Health and Motion Network, we use the best-in-class partnership with American Well. We have an enterprise American Well platform that we use across the whole network so that everybody's on the same connection. It is virtual waiting rooms. It has all that you can connect with patients wherever they are based on your jurisdiction to make sure you can serve them and then track those patients. It also connects with 130 plus hospital systems. So as we go to import that specialty care, it's not teaching a new system, which helps us tremendously. I'll just touch really closely on pharmacy consolidation. What we think it means to the market is that there's a lot of frustration with this consolidation, especially in the self-funded population, self-funded employers, because they don't like a choice of four, and they don't believe they're getting value from a choice of four. And they're looking at going, as all industries like to buy goods and services. I mean, if you're familiar with manufacturing industry, is that they get inventory just in time to assemble. That's just part of their demands. And that's what they're used to, that environment. So having four choices that they consider somewhat dinosaurs in the market, they're looking for choices and they're looking for direct. And as part of that direct is we do have our evolving pharmacy care with point of service dispensing and direct to consumer fulfillment beyond that. So it's a vibrant marketplace. We're extraordinarily pleased to be part of that vibrancy, and we're very pleased to be working with Laurel and with Gateway to better. And we look forward to working with all of you as this market evolves, and we can all prosper together, trying to make sure that we get those consumers the care that they need and deserve. Thank you.
Just a reminder that we are using the app for questions and answers. This session is not excluded from that. So you're welcome to put them in. I will also walk around with the microphone right now for any questions, but even after you leave this session, please feel free to use it. You can plug the questions in. We will answer these and address these questions. You can actually check back in, and I'll make sure to kind of notate that. Additionally, within the app in this session, there is also a handout with some FAQs. I don't know if any of you noticed that. That's in there as well. So we did have one question come in through the app. What is the marketing plan for the network?
That's a great question. As I said, and it's kind of chicken and egg, we need to, I would like to get some interest, like I say, because I think there's no risk. This is our first engagement and our first contract that we have with Health in Motion Network. But, I think once we have more opportunities out there, or more, that we can say we actually have a network of X amount of centers across the country, this already tops, I would love to top what CBS Minute Clinic can offer. I think it's a very marketable entity. But we will have press releases, that type of thing, that we will go out. We'll reach out to more people like Health in Motion. As I said, someone is meeting me here tomorrow who deals in the work comp industry. We've actually had some vendors approach us on things like, we have this medication for multiple sclerosis, but it involves, someone hanging an IV and monitoring a patient for 4 hours. Would urgent care centers be interested in doing that? We'll pay them $600 to do that, but they have to monitor vitals every 15 minutes when they do that. It's that type of thing that we've always felt like, that would be something they might be interested in. Come exhibit here at our expo and talk to them and see if they'd be interested. Well, now we can say, yes, we'll send it out to our network and we'll see. I'm in, I'm out. I'm capable of hanging an IV, and I'd like to do this from 11 in the morning till 3 in the afternoon when I have my downtime, and I'll accept patients during that window. So it's those types of things where it just seemed like we had enough inquiries coming in that we thought we need to make this a little less amorphous and go from a concept to a reality. And so, like I say, there'll be press releases. I think this will get some buzz. Everybody is still very interested in this industry, even though some people are predicting our demise. We're still on the upswing, but we need to seize it while we're on the upswing.
Any questions?
So is there any, so a lot of employers that have the on-site services from Apprentice Health or whatever, they're also expanding that to include dependents. Is there any consideration for the dependents of an employee to be included in the program?
Yes. Yeah, I mean, I think, that's the way we'd want to build it.
Yeah, definitely. And it's about locations. Sometimes the dependents wouldn't be able to come to the central site for either distance or security or whatever the issue. So having near site clinics, and then we also have, direct to patient connectivity at the home also, depending on what the issues are and how much asynchronous communication you need of their healthcare data as a follow-up.
I mean, if you think of a self-insured employer, I'm going to sign on, I'm actually paying the bills, but I might have Aetna as my, managing it, is essentially the administrator of it. But if I sign my children up, then they're automatically in what we're trying to do, going direct to self-insured employers. And what we hear is, over the last 3 years, people come here and say, you need to stop depending on, insurers, the traditional insurers. You need to go direct to employers. But then people come up to us and say, but how? How do I even get started? I can't call up Intel and say, can I meet with your HR department? Well, this is the way to do it. These folks and others that I'm sure we'll talk to are going direct to the brokers. And the brokers are designing the plans, so it goes that way.
And part of our initiatives, and again, you listen to what the customer wants, because that's always drives every equation, is that we've worked with school systems, and they not only want their employees covered with the virtual clinic on site so that the staff does not have to leave campus, but we also spend that slightly and have the urgent care be a triage provider available for the student nurse through technology to get a consult on a child. So there's lots of ways that you can evolve this, and as you start to talk to these different HR and different administrators of the different companies, they all have different needs, and the key to any successful business is how do you service those needs? First of all, recognize what the needs are, and then how do we service them?
So long story short, our next steps are, we'll be sending out things in UC Access, et cetera. The contract will be available and downloadable on our website for our members. We would like to start recruiting people so we can say we have this, because we need to all get together and stand together to fight off the bear. So.
And I would just to add to that is timing is important, because in our side of the business is the benefit cycles is now is the time where you're building product for January enrollment. So it is important that, that y'all evaluate the opportunity, and Gateway to Better is fully available. And I think is that it's something that you really should move on quickly, evaluate, move on quickly.
A reminder again, if you have any questions kind of post this session, please put them in the app and we will make sure to reach out to you with those responses. On the way out, we do have both doors with a scanner. We'd like to scan everyone's badge just so we can follow up with you after the session. Thank you so much.
Thank you.